So it's glad to have you here today. I would say after the robust discussion on education, it sure got my brain cells going in regards to the important issues of today and to the young people. And as a homeschooling mom for 11 years, many of these things are very dear to my heart, especially with all the grandkids. But today, the topic that we're going to be having 3 experts with us today to talk about the health care. And probably as much as education gets our juices going, the next big hot topic, which is very personal to all of us, is healthcare. And so before we get started on the actual forum, I'm just going to have my 3 presenters just tell you a little bit about themselves, their education, their background, and if they would just do that. So if you would give us a start there, Professor. Doctor, sorry.
Thank you, Senator. My name is Janak Joshi, and I am a retired physician. I practiced internal medicine and nephrology in Colorado Springs for 30 years, on my own practice with about 50 employees with several offices. And after retirement in 2010, I got elected to the Colorado State House. I'm currently serving in my 2nd term. I'm also the Republican ranking member on the Health Committee, and I also serve on Finance Committee. I have served on Education Committee in my 1st term too, so sort of gotten all around over there. So I'm looking forward to this discussion, since this is going to be a very major issue in coming months. So I would like to thank you, Heartland, and everybody else who is here for giving me this opportunity.
Thank you for being here. And Peter.
My name is Peter Nelson. I'm the Director of Public Policy for Center of the American Experiment. That's a local think tank in town. And I started there way back in 1998. And
when you were 10.
When I was 10. And so back in 1998, I started out there, and after a few years, I got involved in healthcare policy, mostly with the insurance industry side of it. But then I took a little break from the action and went to law school. I went to the University of Minnesota Law School here in town, and I got a law degree. And I can say I've never actually practiced law, so I think that's a good thing. But not to offend any of the lawyers in the room here. But in 2006, I really started focusing in on healthcare issues and started addressing Medicaid issues at that time. And so I've been very interested in Medicaid ever since that time, and paying very close attention to what's happening around the country. And so I'm very happy to be here.
Thank you, Peter. And Christie?
Can you all hear me? This is a little... Can you all hear me now? Great. My name is Christie Herrera, and I'm Senior Fellow at the Foundation for Government Accountability. Okay. FGA is a health and welfare-focused think tank. We work in all 50 states. And my background, prior to joining FGA, I was the Healthcare Task Force Director at ALEC, the American Legislative Exchange Council. Was at NCSL this week, and it was my first non-ALEC meeting, and boy is it completely different from the ALEC experience. So it's really nice to be with all of you limited government people after being at NCSL all week. If I could, Senator, I wanted to start a little bit with kind of an overview of Medicaid and Medicaid expansion, just to kind of set the discussion. Is that?
Absolutely. That's
Okay.
what I was hoping we would be able to do. That would be very helpful.
Can someone bring up my... Okay.
What is it that you need?
Oh, great. Can y'all hear me ish? I'm from New Jersey. I talk loud anyway, so this should be fine. So I wanted to kind of set the stage and talk about Medicaid expansion and the big picture of Medicaid expansion, particularly who wins, who loses, and why you as legislators should not be fooled by what red states are doing. So how many of you are in a Medicaid expansion state? Okay. And how many of you are in a non-Medicaid expansion state? Okay, good. About half and half. Well, this is what the national picture looks like on Medicaid expansion. And you can read this map like a stoplight. So green means go toward expansion and red means stop. You can see that 27 states accepted the expansion, 23 have rejected it. We hear a lot in the media about this tidal wave of Medicaid expansion, all these states caving. Not the case at all. So just this year, only one state, and that is the state of New Hampshire, has actually expanded Medicaid. Now, Let's start with a really big question. Who do you think benefits the most from Medicaid expansion? I think the answer, hospitals, that's one answer. Doctors, probably. The big winners are not who you would expect. It's not kids, it's not the disabled, it's not the elderly. The big winners of Medicaid expansion are able-bodied, childless adults of working age who, if they worked a full-time minimum wage job, would make too much to even qualify for the Medicaid program. Non-disabled childless adults make up 8 in 10 Medicaid expansion enrollees. So let's leave aside for a second the question of covering low-income parents. What does it mean to put non-disabled childless adults onto the Medicaid program? Now remember, Medicaid is supposed to be a safety net for the most vulnerable. Medicaid was never meant to be a welfare program for able-bodied adults that keeps them from meaningful employment. In fact, when you think about it, non-disabled childless adults don't get other kinds of welfare. They don't get cash assistance. They don't get long-term food stamps. So what we're really talking about with Medicaid expansion is putting a whole new class onto government dependence. Now, one of the things that is a universal truth with Medicaid expansion is that when you turn on the Medicaid expansion faucet, you can never turn it off. So here is a lesson from Arizona. Now, Arizona expanded Medicaid back in the year 2000 to everyone up to the poverty level. Here's how many low-income parents Arizona thought would sign up for the Medicaid expansion. Here's how many they thought were eligible, and that's how many actually signed up. Double what they expected. It's the same thing for childless adults. Here's how many they thought would sign up in Arizona. Here's how many they thought were eligible, and that's who actually signed up, 3 times what they originally projected. Now you see that little drop off there at the end, you're wondering what happened? Arizona ran out of money. So they capped their Medicaid program. Even worse, Arizona stopped heart and lung transplants in their Medicaid program in order to pay for the able-bodied childless adults on the system. Now remember, when Arizona did its Medicaid expansion, that was pre-Obamacare, when you could cap the enrollment. Now with states that are accepting the Obamacare Medicaid expansion, you can't cap it. You can't shut off the Medicaid expansion. Here's the really ironic part. You hear this a lot in states. People think our problem of the uninsured is going to be solved with the Medicaid expansion. The really ironic part is that in pretty much every state that has done the expansion, the rate of uninsured stays the same. So here's a look at Arizona when they started their Medicaid expansion up to today. That number at the top is the percentage of uninsured. You can see that it remained virtually the same. What happened is less people had private insurance and more people went on to Medicaid. Now I want to end really quickly just to kind of set the stage for this discussion to talk about 3 red state Medicaid expansions that you guys might be hearing about. And the first one is the Arkansas style private option. Anyone from Arkansas here today? Okay. You might remember that in 2012, Arkansas was one of the bright spots for conservatives. Republicans took over the House and Senate for the first time since Reconstruction. The first thing they did was expand Medicaid. When you're thinking about the Arkansas-style private option, there are a couple things to keep in mind, and we can talk more about this when we have our discussion, but the first thing to keep in mind is that costs have been through the roof. Now, how many of you have Medicaid managed care in your states? A lot of you. So you know that with Medicaid managed care, you have multi-year contracts, competitive bidding, capitated rates. With the Arkansas-style private option, you get none of that. When you are an able-bodied adult, non-disabled, without children, in the Arkansas-style Medicaid expansion, you can pick any silver-level plan on the exchange that you want at no cost to you. The state pays for premiums. The state pays for deductibles. They pay for wraparound benefits, cost-sharing subsidy. Second, contrary to what we hear about in Arkansas, there's even less skin in the game than even old Medicaid allows. For everyone under the federal poverty level, they pay nothing in the first full year. Now, I mentioned with Arkansas that you can pick any silver level plan on the healthcare exchange that you want if you're in the Medicaid expansion. And when you look at the numbers, the difference between the lowest cost silver plan and the highest cost silver plan is about double. There's also a lack of competition in Arkansas. So they divide the state up into regions, and in 4 of the 7 regions of Arkansas, only Blue Cross Blue Shield offers plans. So, for you economics folks in the crowd, what happens when you have absolutely no price sensitivity on the patient side and absolutely no market competition in the health insurance market? What you get is an Arkansas Medicaid expansion that has completely busted its budget. When Arkansas was thinking about Medicaid expansion, they thought it would cost $325 per person per month. They came up with this private option. They said that would cost $437 per person per month. They negotiated a federal cap with the feds of $477 a month. So are you noticing a trend here? It was went from $325 to $437 to $477. Here's how much Arkansas is actually spending. Their costs are bumping up to $500 per person per month. They have completely exceeded their federal cap. They're actually going to the federal government for a bailout of their Medicaid program. 2 months into their Medicaid program. Under the terms of the waiver signed by Arkansas, who do you think is going to be responsible for these cost overruns? Arkansas taxpayers. The federal government pays for none of it. The second of 3 states I want to talk about is Iowa. Iowa is another red state Medicaid expansion. And you can see these are all the things that Iowa asked the federal government for. But what Iowa asked for and what they got are 2 completely different things. What Iowa wanted was skin in the game. What they got is even less skin in the game than even old Medicaid allows for. Iowa said, we want to charge everyone who comes into the emergency room with a hangnail or a cold $10 to discourage them from coming into the ER. They were rejected. They tried to exclude benefits. They were rejected. They tried to exclude presumptive eligibility. They were rejected. Even worse, after CMS said deny, 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 the few personal responsibility elements that Iowa did put in their waiver, the federal government is making it very hard for Iowa to even enforce it. For example, Iowa's charging premiums for their Medicaid expansion. However, if your income is below the federal poverty line, you cannot be disenrolled for paying your premium. If you're in Iowa's Medicaid expansion, all you have to do is check a little box saying, I can't pay, mail it back to Des Moines, and you're good. There is no one to verify that you have a financial hardship. No one even defines what a financial hardship is. How many of you like country music in the audience? Okay, Kenny Chesney has that song, No Shirt, No Shoes, No Problem, right? In Iowa, it's no premium, no problem. You cannot be disenrolled for not paying. And the third state I want to talk about is Indiana. So Indiana, Governor Mike Pence, and I see Mr. Turner in the audience here. Mike Pence said he is rejecting Obamacare by implementing the Medicaid expansion. So he's rejecting Obamacare. Okay. I can tell you that policy analysts at the Heritage Foundation, the Cato Institute, FGA, National Review, and even the Heartland Institute disagree. This is from the Washington Times editorial board, who said there are enough strings attached to Obamacare's funding of Mike Pence's Medicaid expansion to enable him to open a marionette factory in Indianapolis. So there is a lot of things going around about what Mike Pence's Medicaid expansion is. I will tell you what it's not, okay? It's not a block grant. For all of you who know what a block grant is, and we as conservatives talk about block grants all of the time, you need 2 major things. You need flexibility from the federal government, and you need a capped amount of federal funding. Indiana has neither. Indiana is putting 284,000 able-bodied childless adults of working age onto the Medicaid program. Now, I was with Governor Pence at the American Enterprise Institute when he unveiled this plan, and he quoted Ronald Reagan 3 times in talking about his Medicaid expansion. I remember a Ronald Reagan quote of my own that says, we should measure welfare success by how many people leave welfare, not by how many people are added. Finally, and then we'll get to the discussion, one of the things that we hear a lot about with Indiana is, isn't it great that Indiana is using health savings accounts? with their Medicaid expansion. Well, the health savings accounts that Indiana is using look nothing like the health savings accounts that we have in the private market. Indiana has already had to make so many concessions to the federal government. It hasn't even completed its negotiations yet. They've had to make so many concessions. I'll give you the biggest concession. With a health savings account, right, patients are supposed to pay for their own medical care. In Indiana's Medicaid expansion health savings account, what do you think the minimum contribution is for a non-disabled childless adult on Medicaid? $0. Whoever heard of a health savings account where the patient pays $0 and the taxpayers pay 100%? You know, there's another quote that comes to mind from Milton Friedman, that nobody spends somebody else's money as well as he spends his own. So with that, I'll leave this up here and we can talk about this more at Q&A, but here are 6 things that I suggest that you embrace next session instead of expanding Medicaid. I hope that set the stage for our discussion here today. Thanks for the time and allowing me to kind of illustrate Medicaid expansion in pictures. And
Thank you very much, Christie. That was very good information. We really appreciate it very, very much. So let's start with you, and in light of this information and your experience, if you want to make some comments or add some additional information, I think this would be a good time to do that.
And thank you, Christie, for this nice presentation. Well, in Colorado was one of the states where we implemented Medicaid expansion. I actually had a bill to repeal it this session. Of course, it didn't go anywhere, but we had a pretty good discussion in the committee hearings. And one of the biggest issue was the fiscal. In 2017, going forward, as the federal match will start to go down, and by 2020 it's supposed to go down to 90%, Colorado currently will have about $2 billion for the Medicaid expansion. And if the federal match starts to go down, like you mentioned, we will be responsible for, and any other state which has done. And if gradually that happens, it will bust our budget. I mean, we have about $7 billion in the general fund that we use for the health care, not just Medicaid alone. But $2 billion is a lot of money out of $7 billion. So I asked the fiscal analyst what will happen in 2017, because we'll have definitely one change. That will be the change in the administration in Washington, D.C. So we know for sure. We don't know a lot of other things, but that will be definite change. So our problem is going to be where the money is going to come in. And like you said, and I questioned the same thing, is have you, because the fiscal analyst said, well, you are the legislator, you can actually repeal the bill if you think it's not going to be feasible. And I use the same argument. I say, have you tried to take something back from somebody that you give them? It never happens. So I think I'm with you on definitely on this one, that we are going to see a major problem in all these states, including Colorado, come 2017. And I would like to hear some more from both of you on that too.
Peter, opportunity for you in here.
Well, many years ago, I had loved the fact that we have our laboratories of democracy, and we were able to see what is going on in other states, and we were able to see, okay, I was actually pretty comfortable with the idea that some states were going to expand Medicaid because they had the power to negotiate with the federal government to create some new programs and implement some new ideas. And for states like Minnesota, where we know where we maybe knew it was going to happen, and other states where we just knew it was going to happen, just the political winds were moving that direction, at least in those states, they would hopefully have the power to negotiate. But the laboratories have now spoken, I think. The laboratories have spoken, as Christie has demonstrated, there is no flexibility. And that is a serious problem right now in the political environment. And so I wholeheartedly agree right now with the notion that we need to stop expanding across the country. And we need to start looking right now in states like Minnesota And these, to me, these need to be the new laboratories of democracy for Medicaid, because we've already expanded Medicaid in Minnesota. We've already expanded Medicaid in Colorado, and you're right, we're probably not gonna take that back. But we absolutely can't afford to not look at the current program that we have right now and start experimenting with ways to actually implement a lot of these things that some other states have been trying to do, new cost-sharing ideas and new eligibility level ideas, new ways to bring in competition into the Medicaid program, and new ways to look at how, right now, I'll tell you, we'll maybe get more into this in this conversation. I have concerns about Medicaid managed care, and I don't believe that that necessarily is right now leading to the sort of private market that most of us are looking to implement in our Medicaid programs.
I appreciate what you're all having to say here. And one of the things that Christie mentioned was that, yes, you have these laboratories. The problem is CMS, once you've expanded Medicaid, won't allow you to do that. So what's the answer? If you want to have those laboratories and you want to have those creative solutions, but under CMS, they won't let you do that, then maybe you can comment. Christie, let me start with you. What do you do then? How do you handle that?
Yeah, I think the problem is that if we were designing a healthcare safety net program from scratch, none of us would come up with Medicaid. It's true. I mean, when Medicaid was started, insulin was an experimental drug. So it just goes to show you how antiquated Medicaid really is. The problem is that, as we've all seen, the federal government won't allow you to do anything really creative. There's no work requirement in Medicaid like there is for TANF cash assistance. There's no meaningful cost sharing in the Medicaid program. So what you do is you do programs with state-only dollars. Florida and Utah have actually been coming up with some really interesting alternatives to Medicaid expansion that only target low-income parents and the disabled, right? Because why would we put able-bodied working adults onto a welfare program? Let's target the help for people who really need it. Using state-only dollars, using things like a work requirement, 20 to 35 hours a week work requirement. That's what you need to get welfare cash assistance. That's what you should have to do in order to get Medicaid. Meaningful cost sharing, $25 a month for your healthcare plan, a defined contribution. These are all things that you can do with a state-only program. You can't do it with Medicaid.
Okay, Peter, how about you? What are some solutions then? If CMS won't cooperate and there you are, what next?
Well, right now, I think I look at the stage we're in politically in this country, and frankly, I don't know that there's a whole lot that we can do with the federal Medicaid program. So I definitely agree with what Christie was talking about with looking towards state-only programs. But right now, what we need to do is we need to be hunkering down and thinking about what the next step is, what that next program is. We need to set the legislatures around the country probably need to start setting people in their local communities that they trust to the task of designing what they think the next Medicaid program should look like, because once that political environment changes, the president's not going to be around forever, and in a couple of years he's going to be out, and we're going to have a new administration, and quite frankly, even if it's a Democrat administration, I expect we're going to have much more flexibility to do the things that we think are going to be positive for our citizens and positive for our taxpaying. For our tax dollars. And so right now, I really think we need to basically, close the door, go in the room, and really start having a brainstorming session about what we need to do so when on day one, when that administration changes, we have a plan. And we absolutely need a plan because right now, this program is going to bust state budgets and the federal budgets if nothing changes.
Janak, what about your experience as a representative? Gives you a unique perspective here on our three panelists.
Well, I think I agree what Christie has already brought, that you have to ask people on Medicaid to at least pay something. They have to contribute something, because then they will use the services a little more wisely. I remember many years ago when I was practicing, there was a $2 copayment every time they came to see me. Well, gradually that has pretty much gone away. But people just didn't show up for anything and everything. I mean, when they called and we said, well, you'll have to pay your $2 copayment, they said, oh, well, I just got a little cold. I'll wait another week and see what happens. Instead of just showing up to the emergency room right now for a simple cold or something very simple. The other problem I see is many of our states have medical provider fee or tax. In Colorado, they call it hospital provider fee, which is basically a tax. Well, that was done so that they can use that money to expand the Medicaid. And I finally got some numbers this year really bugging the fiscal analyst. What it looks like that when this 10% goes away by 2020, they will have to get the money out of this hospital provider fee. Well, I know the hospitals are going to call bloody murder by that time because they will get less money. Also, the federal match is going to start to go away by that time. So we are going to have very interesting time in 2017. And at this point, the way we have term limits, that would be my last term if I continue to go on. And I told her, I said, we are going to have pretty good fun in 2017. Come all these things one by one. And we may have these mother load of storms coming from every direction. And with the change in the administration, you are 100% right. Whichever administration is there, they have to control this $18 trillion that we have. And that may end up more in 2 years, who knows. So it's going to be interesting time. So I kind of would love to come back and talk to you guys in 2017 meeting here in Heartland and see how we are all doing.
Yeah, without doubt. That actually leads me to the thought, and I've heard this before, that this is actually kind of a calculated plan of knowing this will fail. And the reason why is that they're really hoping possibly that new administration will go to universal because, oh, this is such a mess, such a disaster, it's oh so hopeless, let's just have universal coverage. And we do away with all that kind of stuff and then that'll solve everything. Now, Peter, I would suspect you might have some thoughts on that kind of thing, or maybe you have some other things to share.
Well, I'm not someone who believes that the Affordable Care Act, Obamacare, was implemented with the design to fail. I think it was implemented in the sausage factory of Congress, and it was destined to fail simply because it's over 2,000 pages long, and you had people that had too much pride in their own beliefs and too much pride in the fact that the central government can actually manage something like this. And I think it's that hubris that carried forward and won the day, and now we're seeing the result. But I do believe that there is a grave concern that because we are failing, absolutely, that the next step, is basically, well, throw up your hands. This doesn't work, and especially because so much of the messaging is, well, this is a market-based approach, and we need to be very careful moving forward that as conservatives that we are very clear that there's nothing market-based about what's happening in Obamacare. There's absolutely nothing market-based about this, and there really wasn't much market-based about the previous system. Our whole goal in healthcare policy is to actually get a real market that really has been non-existent since Medicaid and Medicare and other health policies came about in the 1960s and 70s. And so I do think there is that grave concern that we may be marching down that road towards single payer. However, I do think that there are bright spots, and I really I'm an optimist. And I see right now, when I'm looking at the political environment, I'm seeing everything break apart, and I'm seeing many more opportunities to demonstrate the power of markets to improve health and to improve outcomes for a lot of people.
One of the things that we've talked about legislative before is that one way to kind of break that up a little bit and yet kind of leave a shell of the system in place is to do block grants to the states. In other words, instead of all the hand tying, that whole chart of denied, 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 true block grants, but untying the states and letting them run their Medicaid program without having to constantly go get a waiver or permission to do something creative, and the 6 months to a year it takes to even go through that process, which is missed opportunity time. What do you think about the possibility of actually getting a genuine block grant?
I love the idea of block grants, but we don't live in Libertopia. We live in the U.S., where even the George W. Bush administration rejected a true Medicaid block grant. So I'm not sure if we'll ever see one in our lifetime. I feel like, as Peter was saying, we need to look at ways to reform the current Medicaid program, because all a block grant does is give you a car. You need the map and you need the destination of where you want to go, and the block grant doesn't get you there. So the financing is part of it, but also a true Medicaid reform plan that you will implement. That is what state legislators should be focusing on, because quite frankly, block grants are a pipe dream, and we probably should stop talking about them as a movement. That's my pessimistic opinion. So
I'm not quite so pessimistic, but that's okay.
However, Rhode Island was able to accomplish a global waiver. However, and there's serious limitations to that global waiver, and it has proven to provide some benefits, I believe. However, it certainly hasn't proven to be the solution. And if there is a Republican administration moving forward, it might not be called a block grant, and it might not give you absolute flexibility. But I do believe that there may be much more flexibility through something like a global waiver in the future. I don't believe it's entirely a pipe dream.
Well, I'll tell you, he's referring to the Rhode Island block grant. So Rhode Island went to the Bush administration and said, we want a real block grant, and they said no. And they came back with a global waiver that actually increased federal spending by $2 billion. So Rhode Island was really cute. They did their forecasting, and they thought, okay, in the next 5 years, we probably will spend $10 billion on our Medicaid program. So let's ask the federal government for $12 billion and call it a block grant. And that's exactly what they did. So, you can't say it's a block grant when you don't cap the amount of federal funding and you ask for $2 billion more.
We appreciate that, and that's a good discussion. The other thing is that sometimes we make decisions and on the current administration, because without a question, Kathleen Sebelius and some of these others, Eric Holder or so on, have been extremely, extremely difficult to work with. A new administration can sometimes make a difference in those assumptions. But I wouldn't think that just because you're going to have a Democrat that's going to be necessarily. The other thing is, under George Bush, what we know now about Obamacare and some of these issues, I think, has changed both Democrats and Republicans. So, but Janak, what about you? What do you think about block grants in regards to that?
Well, as a healthcare provider yourself, you kind of know that CMS has been sort of experimenting with mini block grants to hospitals and doctors and all that. I mean, they began with the DRG, which was sort of a block grant to the hospital for every patient they admitted. So they gave them a lump sum amount of money and say, okay, you take care of your patient. Same thing is happening now. For example, me being a nephrologist, I kind of keep up what's going on. They are calling it bundling. So now they give one lump sum amount to the dialysis center to take care of the patient. Well, the dialysis centers are already complaining because they say we can't just continue doing it because they have to cut the cost, they have to actually cut the quality. And they are already talking about shutting down the dialysis center in the rural areas because they say they won't make any money on it. And so this is already happening. So I don't think all the block grants would work. I will give you also an example. Back in the 90s, when we had a de facto president, I would not put the name there, who was trying to do some healthcare experimentation. I was the member of the American College of Physician Executives, and we made some trips to several countries to see their healthcare system. And through that, I went through England, former Soviet Union, Spain, Netherlands, etc. When we were in England, one of the physicians, he was a family practitioner, told he was one of a very similar thing. He was given a certain amount of the money and was told that he can admit his patient whichever hospital will give him a better deal. So I asked him, I said, so when you save the money, what do you do with it? And he says, I can put it in my pocket because government says that I can only use it to improve the quality of my patient, so I can buy a new computer system or buy a new chair or a desk in my office, but I can't take it. And I said, then what good that incentive is? And by looking at your chart here that you are showing us what they deny and what kind of strings gets attached, that's my concern is with the block grants, that they will also come with more strings. And whether then it will be really effective, although we as a state, we know better what kind of quality of care we want to provide, because it's different than in Colorado, then it might be different in Minnesota or Iowa or wherever. We know better, but CMS doesn't think that way. They have the same strings attached to all the programs. So that's where my concern is with the block grants, whether how many strings and what kind of strings they will come with.
I think you have all made really good points. I think that's all really good. One of the things that we've had now was a discussion that was largely based upon those states that have expanded Medicaid. Now, I know about half the room raised their hands, and they're from states who have not expanded Medicaid. And so I think this is a great opportunity for you in the audience today, for some of you to speak up and engage also in a part of this process and tell about your state where you did not expand Medicaid and what that has meant to your state. So if there's somebody out there who could maybe speak for that. Sir, in the way back, your name please and your state.
Janak, I'm a representative from Utah. And, you know, amongst the tremendous challenges and angst that we have, I did hear one word of really black hope that we'll hold on to, and that, as you said there, our president's not going to figure it out first. You contemplate that throughout this week. In Utah, we have not expanded, and we're actively working on it. And, you know, I don't fault other states for trying and maybe not get to where we or I think they should be. That's the beauty of letting the states try, be the incubators and be the innovators. I look at Iowa, I look at Arkansas, I would go a little differently, but at least they're trying. I think if you talk to the folks from Arkansas, and I talked to some, they said maybe it wasn't the best move to tell people that they had to choose a silver plan, that they could choose any silver plan, from the least expensive to the most expensive, and we pay 100% of the cost. I think they're recognizing that now. But the problem, I think, comes a lot from what you said, and that's flexibility. The defense definition or vision of flexibility is just not what the state's definition is. I'll just give you one example, and it ties in with one of your slides. A few years ago, our governor left office and he became the Secretary of Health and Human Services, Mike Leavitt. And we thought, wow, finally, this is a get out of jail free card. We're going to take advantage. So he submitted a bunch of waivers to CMS. He was the boss, right? He was the boss. He was the main guy. He was just our recent air governor. And we thought we're going to get all these approvals and all these waivers that we were waiting for years. We met with his staff and said, yeah, looks good, looks good, looks good. They filter through the process, goes through the bureaucratic phase, and they all come out 2 years later. 2 years later, no, deny, deny, deny. Even though it was our just prior governor who was supposedly the boss, it was just the French bureaucracy. But one of the things that really frustrates us as an example is the treatment of non-emergent care or emergency rooms. Versus going to an urgent care center, even if the doctor's not available. For example, in Utah, the average ER treatment is $1,300. That's the average. Average urgent care treatment costs about $140. A large percentage of treatment that's done in the ER is non-emergent. It's not emergency. It could be done somewhere else. So we went to the federal government, to CMS, and we said, we want to, because we were currently charging people $5 if they went to the ER for non-emergency services. He said, we want to charge $25 if people go to the ER when they really shouldn't go there. They should go to the urgent care center, to the primary doctor. That costs us $1,300, and we wanted to charge $25. going to let you do that, but we do want to know that we're kinder, we're more gentle CMS now, we're more flexible, and we are going to let you increase it for $5. That's it. I said you can go all the way to $8. And we said that it costs us $1,300. Where's the distance stand per person? So I'll just do 2 months ago, I met with my company got down there and met with the new Secretary of HHS, Secretary of Herrera. And I have to say, I like the work better than Secretary Sebelius. Time will tell. There was no room in the, standing on the wall that I was previously. But she was all about flexibility, and yet she has Cindy Mann, and then there's no Cindy Mann, we talk about Medicaid through CMS. And we say, we want to do this, and Secretary of Herrera will say, well, that sounds good, what do you think, Cindy? And so we still got this entrenched bureaucracy that's giving the answers, but I just want to thank the other states for trying. We're looking at Arkansas, we're looking at Iowa. Our governor met with Secretary Burley last Sunday. He's got this plan to try to implement legislative folks have ideas, but thank you for all that you're doing and trying to push the envelope. Our governor's going to what he calls a block grant. It's not a block grant, but it's better to sell it to that state if you call it a block.
Has Arizona taken all of your money since we expanded? Because that's how the governor sold it. If we didn't expand, then everybody around us was taking all of our tax money from the federal government. Have we taken all of Utah's money? Because I don't see it coming in.
Well, one question. That's right. Sir, I do have a question for you. Since Utah is a state that has not expanded, what difference is it? I mean, from what you said, it sounds very much like the Medicaid expansion states, all right? So my question, though, is what is different in your state because you did not expand Medicaid? Is it just simply the fact that you didn't increase the population so you don't have the ticking time bomb like other states do?
The only difference is I get nasty letters. But the federal government makes everything more complicated than it needs to be. They want us to expand from 0 to 138% of poverty, even though the coverage gap only goes up to 100% of poverty. And so they make it doubly difficult. Above 100%, those folks are already taken care of. They go to the federal marketplace and get very nice subsidized coverage. They're good. So to answer your question, and I met with our county mental health folks just a couple weeks ago. They are saying the sky is falling if we don't expand Medicaid, we're releasing again. And I said, what's different than 2 years ago before Medicaid expansion was even an option? And there are a number of able-bodied adults. The ones I'm concerned about, I'm not completely heartless. The ones I'm concerned about are the people with behavioral health, substance abuse, perhaps medically frail. And that's an area of subset that I think we're going to look at. So nothing's changed. We still have charity care. We provided $2 million of state money for primary grants, for primary care physicians to treat additional 40,000 Utahns this year for primary care. So,
Okay.
there are certainly the advocates, there's the same people that die in the streets that I haven't seen any.
I was just going to ask about that. I was really concerned. So that is it. How about another state? We have Utah. What about another state? Sir, your name and your state?
Mark Wade from Montana Senate. I told you about Montana being one of 3 states in education. We're also one of 3 states that have a Democrat governor who rejected Medicaid expansion. The others are Missouri and Virginia. We're still there. We survived. We're not expanding. There's a recent editorial in the Missouri that I should run help and put my name in it. I actually called the editor and I said, really, is this what you're going to print in Missouri? And they took it out. It was on wrong before they printed it. But I think the benefit of not expanding for us is that it's given us the ability to negotiate with the wider community. That now they are trying to come up with ideas. And I think probably there's so much pressure that we have to do something next session. But my view is, because I actually carried the bill in 2011 to come up with Medicaid alternatives and it went nowhere. If if we reject it again, I think we will improve our negotiating position for the next 2 years with the provider community to come up with better alternatives. But I will also tell you that it was a very, very keen vote, and it's very unlikely that we'll be able to stop expansion again because we have such a tremendous amount of pressure from hospitals and providers. And, you know, and frankly, our ranks are becoming thinner, and their ranks are becoming, within the legislative body, are becoming greater. So, but if we are laboratories of democracy, and I think we're actually factories of democracy, it's important for some states to hold back and use the other states to see what the benchmarks should be.
Thank you very much. Now, we've heard from Utah, Montana, and Christie is going to make some comments, but is there another state that did not expand after Christie that I can go to? Is there another state that did not expand that wants to? Okay, we'll come back to you, sir, after Christie.
Well, I want to first thank you for what you're doing in Montana because I really think it's not about being heartless. It's a values question. Do you want able-bodied childless adults on welfare, bringing them into a whole new era of government dependency, or do you not? I mean, if someone worked a minimum wage job for full-time for 50 out of 52 weeks a year, we'll give them 2 weeks off for vacation, they would make too much to qualify for Medicaid, and they would be over the poverty line and go into the exchange. So when you're talking about those folks, it's not really a Medicaid problem, it's a jobs problem. And that is where you as Republicans and you as conservatives win, because when we get these people working, they will get health care. Two other quick points about the hospitals. Some of you might not know that a bill signed by President Obama in April delayed the Medicaid dish cuts until 2017. Now, why is that significant? When Obamacare was being drafted, the hospitals said, okay, we'll accept huge cuts in our federal dish payments in exchange for Medicaid expansion. Now they're coming to you as state lawmakers in order to seal up that deal. But the dish cuts aren't happening. They probably will never happen. Just like the Medicare doc fix, Congress has swooped in and stopped Medicare cuts 17 times in the past 11 years. And many people think the hospitals will never face the dish cuts that were in Obamacare, which means you don't have to expand. Finally, I think you need to talk to your voters and your constituents in a new way. And we saw this in Virginia with a Democrat governor. I live in Virginia, where the House was the only chamber against expansion, against a Democrat Senate and a Democrat governor who sold the Lincoln bedroom while working for President Bill Clinton. Terry McAuliffe is our governor. They said to voters, did you know that according to the Department of Justice, 1 in 3 Medicaid expansion enrollees has had prior involvement in the criminal justice system, including jail time? So think about that scenario. You're taking away from the poor and disabled and low-income kids to give to 1 in 3 expansion enrollees that have had prison time. Did you know that $716 billion is going to be cut from Medicare in order to pay for the Medicaid expansion? Once you start talking about the consequences of Medicaid expansion, people really listen. You remember, if any of you ever watched Saturday morning cartoons, The More You Know, those little public service announcements on NBC? It's the same thing with Medicaid expansion. The more you tell voters about the consequences of expansion, the more they don't like it. And now we see polling in Virginia, 46 to 41 oppose Medicaid expansion. Independents oppose Medicaid expansion. They were able to move African Americans, more people opposing expansion. They moved Northern Virginia, which is the most liberal part of the state, against expansion. You just have to talk about it differently.
Can I add?
Yeah, please go ahead.
Really quick. Thank you. Yeah, and I think while we are talking about the providers, when we had our committee hearings, we were told by our HICPA people that currently in Colorado, the providers are getting paid about 18 cents to the dollar. And everybody in the committee was kind of surprised, not me, because I have taken care of Medicaid patients. So I think the problem is what we already talked earlier during the education discussion is with the Medicaid expansion, the providers have not received any more reimbursement. What has happened is this middleman, all the bureaucracy has sucked up and siphoned a lot of money. And I think that is something we will have to start to look at. We talked about administrators in these school districts. Same thing has happened in healthcare. There are a lot of middle people that, and a lot of jobs, as you know, that have been created where these kind of government jobs, including Colorado. So I think that is something, Christie, you're right, we may have to start to talk about and get the support of the provider community that we want to give you more money so you can take care of all these patients, but can you help us to get rid of a lot of this bureaucracy? And most physicians will be happy to do that if they don't have to hassle.
I think this demonstrates to us the importance of how you communicate. It's like selling a vacuum cleaner and all you do is talk about how it benefits the salesman versus, and so when you're talking to the voters, all those stuff, when you frame your conversation in these things of these kinds of consequences, it does move public opinion and support our approach. So one of the other things that I'm going to get you, sir, back there, is the fact that as a nurse as well, I have noticed increasingly there are also becoming shortages of medications and drugs. Fentanyl is just one of them. There are many others as well. I think it's going to start affecting even some of our insulin diabetics. And it's of a great concern, and it's just kind of there. Nobody wants to scare anybody about it, so it tends not to be talked about a lot. But increasingly, these kinds of policies and that pressure are having that effect as well. We have a gentleman in the back, and then we're going to, if you could just give us just 30, 45 seconds a minute summary of your state not expanding.
South Dakota, now I can from South Dakota, but we didn't expand. We blessed the governor for that. We got a lot of pressure from frankly the hospitals to give these extra dollars, and the other party for me is saying, well, we're passing out $200 billion in economic growth for the state because we're not taking these federal dollars to do it. But nobody's thinking past 5 years and 90 or 95% of the money, because if you look at Medicare, that used to be something that we paid very little for, and now we're up to almost 50%. South Dakota, as our income levels go up, so does our Medicare South Dakota payment. And I mean, we've had years where we've increased our costs by as much as 11, 12, $15 million. That doesn't sound like a lot. We don't spend $3 billion a year. We do now. Started. Nobody's looking far enough ahead. The government doesn't have the dollars to do it the way they're doing it, and it's going to cost the states to keep it going. You have to get into it and have no way to get out of it. You're just pickled up with it.
Thank you very much. Appreciate that. We have a couple other hands. We are running. Pardon?
We're good.
We are good? Okay. One of the things that we're going to do is I have a couple of hands that we're going to do there, and then we're going to have a little bit of what are some more solutions, what are some more ideas, because one of the things I always say is it's great to talk about the problem, but I just don't want to stew in the juice. I want to move on and say, what can we do about it? Let's get out of the juice, right? And so I know that we have many thoughtful folks here, but first, gentlemen, we have one over here, and then I'll go to you. I'll alternate sides, sir. If you would go ahead, sir, and just give your name and state.
I actually, well,
And also, by the way, we have a microphone up here, you don't. So speak as loud as you can.
I'll talk about it. I'm Senator Jerry Bay from Boone, Iowa. And one of the things that we worked on is we have a Democrat Senate, a Republican House, and a Republican governor. And so our plan was a deal that was really driven by the Senate Democrats because they wanted the full expansion, and we were trying to hold back, and so that compromise thing was a result of working through that. But my real question is, you said 8 out of 10 able-bodied people are what's going to be on this expansion. Now, if I say that on the Senate floor, the first question I'm going to get is, where did I get those numbers? Because when Senate Democrats spout out numbers like we're going to help 100,000 kids, everybody just goes, oh, okay,
Yeah.
we need to help 100,000 kids. If I say there's only going to be 3 kids and there's going to be 100,000
Yeah.
able-bodied people, they're going to say, where did you get those numbers? And so my question to you is, where can I get those numbers and how can I substantiate that? So when I get up and I try to make an argument like that, I have some facts that I can show. That's
Sure.
my question.
And I'd be happy to share my slides with you. I have state-by-state breakdowns, but that number comes from the Urban Institute, which is no member of the vast right-wing conspiracy. They're a left-leaning think tank that looked at the Medicaid expansion population in states, and they measured how many were parents and how many were childless adults. Kids are already covered, pregnant women are already covered, the disabled are already covered, the low-income elderly are already covered. So when you're talking about Medicaid expansion, it's putting able-bodied working-age adults onto the program.
Well, that was wonderful that we could have such a quick answer for your question, and I'm sure Christie will respond to that. Okay, sir, you're next then.
I was just responding to your question. Brian, he's from Texas. We did not expand Medicaid, and Christie actually helps with that quite a bit. We work with her on this. And as the gentleman pointed out, a lot of those folks are covered already being covered. So that helped us. When the hospitals called me, told them that. And we've also told folks that even though it's 9 and 10, we don't have a 10% the feds don't have a 9%. It's not there.
That's true.
And also, we obviously describe Medicaid as the Titanic, but we're people on it. There's more possibility, it's happy with it. So far, that's worked. In Texas, our governor, it's been a big issue. He was strong, but we have to come to the House and Senate. So thankfully, it wasn't much of a fight. We still got to win the war public opinion, but we're making progress. So it's been great for us. The sky not falling. And so far, so good.
Congratulations.
I would say, matter of fact, that the states who have not expanded, the fact that your sky has not fallen, even the big blue sky of Texas and Montana, to be fair, the blue sky state, that stands as a marked statement about the expansion, okay? The mere fact that your state is not expanded and you go on, the longer you go on like that, it makes the contrast even more strongly and makes the point then of saying, then why should you if you can function? But I think the interesting thing for you is I would suppose that those states who have not expanded, do they have more flexibility? Do they have more options because they have not expanded?
Well, I mean, we've already talked about the fact that in Christie's presentation that Iowa, when they tried to, they were denied. And so, I mean, at this point with this administration, no, I don't think if they are going to choose to expand or they want to work with their current Medicaid program to make some changes, I don't think they have any more options than expansion.
And if they don't expand, they're in the same boat, right?
And if they don't expand, they're in the same boat that they're in right now. But I think it's also important to note, and Christie might know more about this research than I do, being uninsured and getting on Medicaid if you're uninsured, it doesn't necessarily improve your health. And that's another thing that recent research out of Oregon is showing us. But it does increase the number of people going to the emergency room. It doesn't necessarily increase your health, but it increases costs in the system and it increases demands on the system. If you're a state that hasn't expanded, I think it's important to note that Medicaid isn't necessarily a health improvement for your citizens. And that, at least for your states, that gives you time to think through things. This isn't something that, we've got to do it now because the health of our citizens depend on it. The health of your citizens are getting treatments and getting care through other avenues.
That's right. One of the things I've noticed too, that there are incentives mentioned quite a bit, and it has been amazing to me. And if you think incentives don't work, look at the Sunday newspaper and all the ads. Isn't it amazing how much people will go through for coupons and shopping based upon what's on sale or the use of a coupon? They actually work quite well. And that's where I think in the education one, where you incentivize the parents to work with their own children. I think health savings accounts had some good things there if they are structured. not as phony HSA, but in a genuine one, can be helpful. We're going to talk about some other ways to maybe, what are some of the solutions? Now what do you do? And we have a doctor here who's also a legislator, and I'd love to hear some of your comments.
I just wanted to give a little bit of Kelly from Arizona. So Arizona did expand Medicaid, and some information came out this week about some statistics. And so we've got 25% more people on Medicaid than we did before, since January. We've gotten 294,000 more people when we were told we would get about 200,000. So we're about 50% over what that is. Unsurprisingly, the childless adult category, the one that was directly affected by things that we put in place in the legislature, has grown the most, from 68,000 to 250,000. So don't think this is cheap. At this point, that population is being paid for by the hospital assessment, that I believe is a tax.
It is a tax.
Just because you write in the legislation that it's an assessment and it's a fee, it really is a tax. So we hope that the courts will prove that out. Since in the first half of 2014, there's been 75.2 million collected in assessments from the hospitals. So don't believe the projections that are out there, because as we saw in Arizona before, and we were not able to learn from our mistakes, you're told one thing, and generally it's 3 to 4 times more people and more costs to your citizens in the state. So just be very, very careful and hold your ground if you haven't expanded.
Okay, we're on a very short time limit. Again, I want to really focus on, okay, what's the solution? We know the problem. So what are some solutions? And if we're going to knock something and saying it's not possible, that doesn't mean it isn't valid, because I'm more of an optimist, and I think circumstances change. But would you like to?
Yeah, I have a question which might open this up. You mentioned earlier, Christie, Florida has a fairly unique program. I believe it's called the Medicaid Cure, which is actually a very unique approach that works in the current system to improve it. Can you tell us more about that?
Sure.
Right,
Yeah, I think reform of the current Medicaid program is essential. And Florida, Louisiana, Kansas, all 3 states that you should look at. In fact, at NCSL this week, one of the things I heard over and over in the healthcare sessions was that you had to expand Medicaid in order to reform it. And that is absolutely not true. It's like you want to buy a shiny new Corvette and you have this like old beat up trailer attached to it. And that's the only way you can drive it off the lot. That's not the case at all. In fact, the states that have gone the farthest with Medicaid reform, Florida, Louisiana, Kansas, all big red states and big non-expansion states. If I could run through, these are my 6 things that you should do next session. And I'll talk about the first 3 of them because I think they're really important. The first is a Medicaid audit. Illinois was an early expander of Medicaid. They wanted all those sweet, sweet federal dollars, so they did it, I think, like a year and a half ahead of schedule. And their fraud and abuse was rampant. So they said, okay, we know that when people go on to Medicaid, they also get signed up for food stamps. You know how it is. So for welfare programs, we want to narrow the front door and widen the back door of Medicaid. So in Illinois, every person that comes onto the Medicaid program, their income and assets are checked among 17 different federal and state databases, and every 6 months thereafter, they're checked. The Republicans are in a super minority in the Illinois House. When this bill went through, 0 no votes. Every Democrat voted for it. Did you know that once they were going 5 years without checking Medicaid eligibility? Now it's every 6 months. Of the 164,000 cases they reviewed, more than half were fraudulent. They saved in 8 months $1 billion, billion with a B, to their Medicaid program by doing this audit. This is a blue state play. Illinois has done this, Massachusetts, Pennsylvania, New Hampshire has done this. If you're talking about creating a pot of money with which you can help low-income parents and the disabled and the medically frail, and you don't want the federal dollars because of the strings attached, do the Medicaid audit. Politically, it will sail through the legislature as it did in Illinois, and it will save you big. Second is a gap study. So any of you who follow Alaska, the governor rejected Medicaid, and he called it a hot mess in his press conference. The first time I've heard hot mess being thrown around by a governor, but that's how he talked about Medicaid. And they said, okay, instead of expanding Medicaid, we are going to document in one place all of the charity care initiatives that are going on, all of the government programs that we fund, the free dental clinics. So we want to see, for uninsured Alaskans, how much care is there out there today without expanding Medicaid? What they found is two things. Alaska found that their gap population was a lot smaller than pro-expansion people were expecting. And two, they found that largely Alaskans had great access to primary care. There are 250 locations around the state where you get primary care in Alaska. And so you're going to audit your Medicaid eligibility, but you also have to audit all of the services that are out there today so people know about them. And the third thing I want to mention is from South Carolina, and this is really cool. Nikki Haley is another non-expansion governor, and she said to her hospitals, DISH will no longer be a blank check for you. We're going to do pay for performance with all of your DISH funds. You're not just going to get a check in the mail. You're going to have to do something for it. You have to work for it. So she said to the hospitals, I want all of you to write a report of how many uninsured patients with chronic conditions come through your emergency room, and in that report you're going to tell me how you're going to keep these people out of the emergency room. If you don't write the report, we're going to dock your DISH 2 3/4%. If you do the report, we're going to give you a little boost. What do you think happened? All of the hospitals did the report. None of them wanted their DISH funds cut. So start to think about, the hospitals that are crying for Medicaid expansion funds. They're getting billions and billions and billions of dollars a year. Every hospital in your district, it's either a 2-crane hospital or a 4-crane hospital, right? Start to think about conditions that you put on that money. South Carolina is beginning to do it, and it's something you should look at.
And I want to add a little bit to that number 3, because I think, to me, right now, when you look at the Medicaid programs that we have across the country, there is very little focus on outcomes. There's very little focus on measuring whether we're actually helping people, we're measuring whether we're actually working towards keeping people out of emergency rooms, working towards lowering readmittance to the hospital after a procedure. There's very little measurement of that going on, and that has been, my biggest criticism of the state of Minnesota. The state of Minnesota, we basically write a blank check to our managed care health plans, and we don't know what they do with that check. We have no idea, and there's so many states around the country where you just don't. You write a blank check, they agree to provide certain services, but there's no accountability. There's absolutely no accountability in the system. And so to me, right now, before a new administration comes around that might give us some more flexibility, we need to develop policies that actually introduce accountability to our managed care health plans. And that's maybe happening right now in Florida. I'm encouraged by what I do see in Florida. However, we need to be looking at all of the all the managed care plans across the country. Figure out ways to look at outcomes and to provide accountability to that system.
Well, thank you very much. I really appreciate all of you for being here, Dr. Janak, as well as your work as a legislator. Peter, your work in the Center for the American Experiment and other think tanks. Christie, your expertise was able to come forward in all your intensive studies. I especially appreciate 6 things you can do next session. That is welcome very, very much, and to all of you as well. Thank you, and that concludes our panel on healthcare. Thank you.
Thank you so much. Yeah, we're just going to get set up here. We do have a speaker right after this. It'll be our keynote, and then we'll have a little bit of a break, as well as serving lunch. So just stick around, don't move too far, and we'll just get set up right here. But appreciate everyone. And thank you to all the panelists.
That's